and all the delegates from SAARC countries as well as my colleagues here. I hope all of you, because we tried to put that insert of SAARC conference in the bag, this should be there. If not, I will try. There are multiple copies in my office. So, is there insert in the bag of the SAARC? Yeah. So, Dr. Azad had given that responsibility to me that one brochure you have to put, whatever it may be. So, I'll, sir gave me a topic of early recognition and management. This may not have anything to do because I was responsible for bringing out guidelines in AIOS, and twice we have brought it and we have revised. And I'm happy Dr. Mallika is here who helped me in revising those guidelines also. So I'll just run through this. End off, you all know, is devastating. This is what is ideal, but this is what can happen, which is very serious. And as far as I am concerned, one case disturbs my peace of mind in case it happens, or if it happens in my hand, it is worse. But if there are series of cases, you have to close your OT. But this seriousness comes only for the operating surgeons. And he is sad, his family is sad, and everybody, he does not want to operate till the time that patient is okay. That is very, very important. So I believe there are always two C's which are important, because the cut has to be there, whether it is 30 gauge needle or 27 gauge or a routine surgery, and that cut will introduce some possibility of bacteria going inside the eye. Higher the pathogenicity, like Pseudomonas, will require few colonies to produce a clinical picture of endophthalmitis. So therefore this concept came of colony forming units, or the load, how much load goes inside the eye. So but each cut you have to, therefore prophylaxis can we reduce the load which is going inside the eye. So but it's a disaster. Crucial thing is time, because if you manage in time, results by and large are good. And aim is to prevent phthisis bulbi, because this patient should not, which is again to that eye is murdered now if it goes into phthisis bulbi. So always, as I said, two things are important. One is that eye should not get lost, because otherwise your practice can be ruined sometimes, because if eye gets lost, because this word of mouth will spread everywhere. Operation was done here and vision was not recovered. Second, which is becoming very, very important in today's world of Google and everything, all the families, all the patients very well informed, never do bad mouthing. Anybody of you can have this infection, and court cases and convictions are increasing.
With sugar, no.
So therefore bad mouthing should not be done. How to save these eyes is best is prevention. In case you can't eliminate endophthalmitis, because if you don't operate, then only you can. Otherwise, you see, anytime you give a cut, it can happen. So therefore prevention, a lot of steps have been enumerated. All of you are aware of this. Rule out local cause of infection. Per-operatively, apart from sterility of the instruments and good quality irrigating fluids, betadine is one time tested thing. Drape, so that lashes everybody drapes, but sometimes lashes are still poking out, and nobody nowadays cuts those lashes. Then good wound construction, believe me, is very, very significant. And whenever in doubt about the wound integrity, put a suture, even though you may have told the patient, but it's a sutureless surgery, but there is no harm in the best interest of the patient. The other thing which is assuming a lot of importance is intracameral antibiotics at the end of surgery. Believe me, whatever flora goes in, generally either it is a fluid or instruments, or this peri-operative, peri-limbal flora, whatever goes inside. So the purpose of this is that it can reduce that load whichever has gone inside. So 3 antibiotics, I think all of you are aware: cefuroxime, Vanco and Moxi, extensively studied. Vanco from Canada and cefuroxime in Europe, and Moxi primarily from India and also from US. If still it happens, then you have to be very prompt in treating, and in treating, as I said, early diagnosis and prompt treatment is important. This slide is just to highlight the role of prophylaxis. It has increased from 2006, I think, was the year when cefuroxime ECRS results were announced, and very, very powerful data. And today, lot of surgeons, we'll ask Dr. Vinod, who is a very high volume, Subhash, so many people are sitting here, Vibhuti, do they practice regularly this or not? So heartening feature was this, when David Chang put this on the American Academy website. I copied this from American website, that based on the Arvind Eye Care study of lakhs of patients, now Chang recommends undiluted moxiflox to be used at the end of each surgery. So key issues, as I said, are delay. delay from diagnosis, delay in giving treatment. You have to differentiate this patient from TAS, lest because TAS treatment is totally different. And why we need to differentiate is, as a pathogenesis, treatment, prognosis between TAS and infection are vastly different. TAS is non-infectious, and it's also known as sterile endophthalmitis. And exact incidence, you see, I think TAS happens in all patients, but they are generally mild and go away with the routine steroids what we give post-operatively. But there could be a lot of causes of TAS, apart from endotoxins, viscoelastic residue, so many causes have been implicated. Solutions, whenever you change a irrigating solution from a standard to a whatever other, you may encounter TAS sometimes. Preservatives, intracameral anesthetics, all have been blamed from TAS. Important thing is to realize that symptoms of TAS occur very quickly, within few hours, maybe 12 to 24 hours, and this patient will have the entire cornea, limbus to limbus haze, corneal edema, visual acuity will be down, and IOP is generally not low in these patients. In endophthalmitis infectious, because of this cyclitis part, IOP is low or sometimes higher, but generally lower side. ENDOPH in contrast is defined as inflammation with exudates. Therefore, I put with here, that exudates have to be there in the vitreous cavity for it to be labeled as a classic picture of endophthalmitis. And a lot of causes are there, early, delayed, acute, subacute, chronic. Although gram positive, coagulase negative is the most common, but believe me, in our country, gram negative, or even in Asian part, gram negative fungi are slightly more important. You can classify based on infectivity, mode of entry, and etiological agent. Infectivity, you can further classify exogenous, endogenous. Within exogenous, you can have traumatic, postoperative blebitis, fulminant, acute, subacute. Based on etiology, you can have bacterial, fungus, parasitic, and these are the common bacteria which are there. I'll just rush through it because I think more important is what Dr. Azad said, that they need to frame some guidelines. Type of presentation, fulminant if it occurs within first 1 to 3 days, or chronic if it is or delayed, which is after a couple of weeks of surgery. And in chronic, generally the suspicion is either towards fungus or a P. acne kind of organism. Lab diagnosis is a must, not from the point of view of starting treatment, but from the court of law. If you do not send smears or if you don't send for culture, it is mandatory that any patient who has a suspected endophthalmitis, you are giving intravitreal, please send material for culture sensitivity. Because the sensitivity pattern may be different, firstly. Secondly, if by chance patient does not behave well, people can ask you in court of law, culture aapka kya tha? What was the culture sensitivity? So it is important. Postoperative endophthalmitis, these are some of the features which can differentiate infection versus inflammation. No need to detail on this because all of you are wise enough people. And color of the exudates ultimately may help, yellowish color in favor of that and whitish in favor of this. So this chart I had made long time back where you can differentiate, and it is helpful sometimes. So, but sometimes you still may not be able to make it. So any patient post-operative period, you have this patient has unusual pain, decreased vision, lid edema, chemosis. Because chemosis and lid edema generally do not happen in TAS, they will generally happen in infection. Corneal haze, hypopyon. If these are not getting corrected, always tilt your diagnosis towards infection and institute early treatment. So these are a couple of symptoms which the patient may come from, complain, like first post-op day, pain or reaction, but pain may not happen in all. You see, 25% maybe may not have pain. Then symptom-wise, decreased glow is the most sensitive but not specific, because obscuration of glow could be because of so many other reasons. But if you find exudates, I think this is 100% specific for endophthalmitis. Sometimes we may get combination of both. This is a short picture of endophthalmitis, but sometimes you may not see all this. So what do you do then? We dilate, try to do slit lamp, indirect, and see wound margin. This may give some clue. And if this diagnosis gets confirmed by any of these features, sometimes I will pay a lot of attention to poor vision, very poor vision, 6/60, and there's a lot of AC reaction. Then we may consider giving intravitreal antibiotic treatment. So I'll just run through a couple of cases from our. This is one patient who had. There are two patients in fact, different eyes. So this reaction was more than usual. So here this chart becomes handy. So, and in such patient, I will not advocate giving intravitreal. Try steroids locally, but load this patient steroids every 1 hour, 2 hours, and also cycloplegics. Very important to give cycloplegics along with it. So this and follow up. Very important to follow this patient. So this patient, fortunately, after a couple of weeks, recovered good vision. So another patient, lady, RK done long time back, now cataract done. Presented this picture of unusual reaction, but I thought this is inflammation only and not infection. So loaded this patient with steroids. Fortunately, after a couple of weeks, good recovery. Just to highlight these two cases, that all reactions do not require intravitreal antibiotics. This is a short patient where all the things are present for this thing. This requires immediate treatment. What, when and how, I think we had these guidelines and all of you are aware. As of now, you have earlier the better. You treat earlier, better results are there. And choice of drugs, I think it's pretty standard now that majority of the people will give Vanco and Kefta. You can use Amica also if you suspect gram negative, because Kefta sensitivity has come down. Amica, the issue was about macular infarction, so therefore aminoglycosides went into disrepute and Vanco Kefta became more popular. And this chart we prepared in AIOS just to stuck in the OT wall, so that you can't memorize how to dilute these drugs, because dilution errors sometimes can mar the results. Always better to decompress the globe, because if you are giving 2 injections, I can tolerate 1, because I cannot tolerate 2 injections of 0.1 ml each. Otherwise there may be compromise of arterial perfusion also. And best way to decompress is biopsy, because this yields the maximum culture sensitivity material. But if you are not very familiar, you can do a paracentesis, because we don't advocate pulling the vitreous too much, otherwise there could be issues with the vitreous based traction. And always you have 2 separate syringes and slowly injection has to be given. And we also do not forget the adjunctive treatment, although EVS was not in favor, but we keep giving this adjunctive treatment. Very important after injection is to follow up, because within first 1 or 2 days you will be able to decide whether this patient is stabilizing, improving or worsening. Any worsening, prepare the patient and the family that he may require a surgery. It was very important to have compliance from the patient, because if patient does not, because he may go away from your practice. If there is no worsening stabilization, continue this treatment, medical treatment. This is one such patient who received Vanco and Kefta. Slowly pupil got synechia broke down, dilatation, glow came back, and after 3 weeks this patient recovered. But everybody may not be lucky enough, believe me, in anybody's practice, that he has good result. So I am showing only good result, but bad results also are there. So, but if it does not respond, I am not a very fan of giving repeated intravitreal, unless it's a fungal or you recalcitrant to vitrectomy. Then we may sometimes give every few days amphotericin B. But by and large, we do not repeat intravitreal and prepare for vitrectomy. Or if the load is very high, like this situation number 4, this may not respond to intravitreal antibiotics, because the load is very high. So vitrectomy, by and large, tradition has been, when we were students, core vitrectomy, but nowadays I think everybody does radical kind of vitrectomy. You go inside and remove as much as possible, even from the vitreous base, indent. If hyaloid is interfering, peel off hyaloid. We will not show any videos here because time is not so much. But before you enter vitreous cavity, very prudent to clean up the chamber, because if you don't, believe me that you will do a messy job in the vitreous cavity. It's always important that you make a stab incision, put this AC maintainer. This cornea is edematous. Further edema because of the lights. ये lights थोड़ा कम कर दें. ये light कम कर सकते हैं? आप लोग सब मोबाइल पे खेल रहे हो यार, थोड़ा सा यहाँ भी ध्यान दे दो. अच्छा ठीक है. Then take a bent needle. Ceiling light. सारा बंद कर दो. अच्छा चलो ठीक है, कोई बात नहीं. आप बैठो, सब मोबाइल देखो. ये सब मोबाइल पे खेल रहे हैं. 6 बैठे हैं. कर दो, चलो कोई बात नहीं. चलो, we'll any case, basic job was to show that remove this exudative membrane over the surface of pupil. then the media will become clearer. Because if you directly enter vitreous cavity, hazy dikhega and you will not be able to do a good job. So once this membrane comes out, the pupil sometimes will dilate, and then you enter the vitreous cavity, you will do a good job, precise job, visibility will be more. So here again, these are a couple of pre and post op patients of photographs. Here we injected oil, this was gram negative Klebsiella. IOL removal is not a must, but in patients who have recurrent infections or fungal or very severe, I try to then take out, because if he has undergone multiple vitrectomies not responding, the organism may be hiding in the capsular bag or near the base area. So this patient presented with a corneal abscess. You can see this abscess had multiple injections also. So I took up for vitrectomy. I was not prepared for IOL removal, but since could not made headway, it is important that you inject your trochlear straight rather than angle. It is because it will penetrate into the vitreous cavity directly. So here you will see that we try to clean up the anterior chamber. Nothing was visible for a very long time. In the process, the IOL got mobilized, and this IOL then I had to take out. Could not leave this behind, and this IOL then made a enlarged incision, and this IOL had one haptic missing, meaning thereby there was some problem during the initial surgery also. Then do base dissection, remove each and every bit from the anterior chamber. Also pay attention to this connection between the abscess and the intravitreal cavity, and because from here the organism entered. Close the sutures and then do base dissection, and at the end I injected silicone oil in this patient, and fortunately this patient had reasonably good vision at the end of 4 weeks. The abscess became a opacity, and this is silicone oil reflexes. In post-traumatic patients, there may be sometimes foreign body. Post-traumatic is marred by polymicrobial infections also. So here is a patient, just to show that this is a foreign body here, very near to the posterior arcade. Rush is not to remove the foreign body. Rush is to clean up all the membranes first and do all the base dissection first. So I have removed these membranes. You can see these membranes, tease these membranes, free the foreign bodies. For foreign body should be freed, and after do base dissection in the periphery. There is no rush to remove the base foreign body here. And after I was satisfied, then I injected couple of drops of PFCL just to stabilize the posterior pole. Very important foreign body to enlarge the incision, because a lot of times this foreign body gets stuck or falls down once you are removing through a smaller incision. Here iron, this is iron foreign body. We are using this magnet. You can use forceps also, and then this foreign body comes out through this enlarged incision, and then we close the case. Fungal endophthalmitis clinically present like this. You have today voriconazole. A lot of us give intravitreal voriconazole, but believe me, a lot of these patients of severe patients of fungal require multiple vitrectomies and multiple injections of amphotericin B. So we'll rush through this. We will not show this. These are proven patients of fungal who have had good results. P. equini can present like recurring and relapsing courses. So here we have either you cannot inject directly into vitreous cavity because the organism is in the bag. So you give injection in the bag, vancomycin, either by limbus route or by pars plana. If it does not respond, you can do a vitrectomy and do a partial capsulotomy so that the antibiotic which you inject can gain access into the bag. Sometimes you may have to do IOL removal also. So I'll have one example of each. This patient responded very well to in the bag injection. This patient we had to do a vitrectomy with partial capsulectomy, IOL still inside. In this patient we had to mobilize and remove the IOL also, and then only we got the result. Situation number 7 is very severe, which is because of now becoming popular intravitreal injections. This is after Avastin. This is after Ozudrex. So just to tell that any injection inside the eye also can develop this picture. If the cornea becomes involved, then prognosis becomes poorer, and then either you keep giving injections or take help from cornea colleague, where he will do this temporary keratoprosthesis, and this button which is the melted cornea is removed. You You see how much infection is there in this eye, and once this is removed, whole bulk of the infection load has decreased quite a bit. Then you temporary crater process is fitted, sutured, and after that you make this incisions and do a 3-port vitrectomy. Got slipped away in between. Yeah, vitrectomy is done, and after that is done, then remove this temporary crater processes and put a graft here, and this can save this eye then. What happened? So last situation is, which is very important from practice point of view, is how to talk to the patient, how to break this news that unfortunate infection has happened. Best is that one person should do the talking, either the operating surgeon or the medical superintendent of the hospital. Otherwise, media is waiting for you to publish in the press that such and such hospital, such and such doctor was responsible, and this whole practice may go down. So therefore, let one person only do the talking, because they are trying to exploit kya hua, everybody they will ask. Plus, whatever you do, please write it down on the case sheet. Documentation is very, very important. If you don't, then you can be, caught. Because it is not important that all eyes should become 6 by 6. It is not important that all eyes should be saved. Important is your effort was there you planned your treatment correctly, which is very, very important. So documentation is important. And breaking bad news, as Buddha said, our wounds are healed only when we touch with compassion. Have compassion. Just realize how much he is suffering, how much his family is suffering. So therefore, ensure privacy, empathize, and talk to him. Talk, and talk. The more you talk, more he will become compliant with your treatment. A lot of new antimicrobials are also available, just in case the sensitivity pattern is different or it's a very virulent. You can try all this piperacin and tazobactam also. So just to summarize, I have tried to present before you how to differentiate between TAS and infection, what to do in these situations, how to tackle these patients of recurrent endophthalmitis or fungal endophthalmitis, and if there is no response, what to do. And very, very important is about the AC clearance and the concept of radical vitrectomy and base dissection also. And I do not hesitate to put in silicone oil if the infection is very, very severe, because silicone oil sometimes is severe for a lot of these eyes. So early diagnosis, prompt, appropriate management, not relying only on drops, can shift from this sad face to a smiling face also. Thank you very much for your kind attention.
Thank you very much, Lalit. We'll now.
I recall one keynote presentation in American Academy, from a very senior fellow on AMD. And I thought I'd heard a lot about AMD from this very experienced surgeon. And what I heard, there was the history of AMD and what's all about AMD. Nothing new, as a matter of fact, but the gentleman was talking his experience on AMD. Before coming here, I was attending this cluster endophthalmitis session. I attended almost half of it, and there most of them were of the view that the endophthalmitis is not the doctor's fault, and especially cluster endophthalmitis, not the occasional endophthalmitis. I stood up there and I said, until now, I thought the blame goes to the surgeon. If you have to point who is responsible for endophthalmitis, I think it's the doctor who let the bugs enter into the eye. No matter what size of the wound is, but it is him who should be responsible. They didn't quite agree with me in the sense that in cluster of endophthalmitis, there are so many other things involved in a kind of, what I mean by that, so many materials, the theater, outside. And I thought, today, what I feel is that these incidence of ophthalmitis I was reading, is about 0.04%. It was 0.1. And with the advent of phaco surgery, where you make a tiny incision, about 2.2, 2.8, less likely that you let the bugs enter into the eye. So the chance of endophthalmitis should be very much less. Today, our surgeons in Nepal, they all want to be phacosurgeons, obviously. Unless you know how to do cataract surgery, I don't think you will be called an ophthalmologist. And the cataract surgery today is a phaco. And all new surgeons wouldn't like to do phaco. And in Nepal, you know, for this kind of training, they go to the plains where they do about 100, 200 cataracts a day to learn phaco. And unless they have done about 1,000 or 2,000 small incision cataract surgery, they won't be allowed to learn phaco surgery.
So is there a limit set in
Yeah, there are centers where they say you got to do 1,000. That's where we send the patients. And unfortunately, most of the patients are coming from across the border. Anyway, having said that, I always still feel, if not cluster, most of the endophthalmitis is to be blamed to the surgeon. I know a story about, you know, Abraham Lincoln, I don't know whether it's a true story, was asked to cut down the trees from the garden in 1 hour by his father, and you know what he did? He spent half an hour sharpening his axe. So you got to spend time in preventive. You got to be sure the surgeon has to be careful. If he suspect anything, okay, I'm not going to operate this patient. You know, kind of like this. So this is what it is. You know, prevention is more important when it comes to endophthalmitis, of course. So that's, having said that, and I want to touch my experience in ophthalmitis, our experience. As a matter of fact, I have not been operating for a while, but I remember one case of me which I never going to forget is a patient who second day developed high opium, and third or fourth day I was no PL even, and I had to within a week to eviscerate this eye, and we grew pseudomonas there. You know, only one case I remember. So that's what it is. So today, what I'm going to talk about, two topics. You know, our problem: endophthalmitis, mainly cluster endophthalmitis. Those have been reported. Otherwise, normally no one will report occasional endophthalmitis. All right. So we have got few publications from Nepal where they have published their experience on cluster endophthalmitis. And then the second part of my talk will be endophthalmitis, and I reckon it's not infective. Probably it's non-infective or allergic or something like that. Okay, here you are. Endophthalmitis to me is either exogenous, which is infective, and I have got another thing, non-infective. And we're going to talk about post-operative endophthalmitis. I'm not going to talk about post-traumatic, or I'm not going to talk about post-fistulous operation. And I'm going to talk mainly cluster endophthalmitis, post-operative, obviously, infective. And the second, I'll be talking about non-infective, which we label as seasonal endophthalmitis. Our experience there. And I
question का अच्छा
okay, this is Nepal, and you see, you know, there are quite a few very good tertiary eye care center near the border of India, and that's where they operate about 100, 200 cases a day, you know, and the operation they perform usually are small incision cataract surgery, and now recently they have started doing phaco surgery also. So this is cluster endophthalmitis, and there are different definition of cluster. If you see about 4 or 5 cases, same day, same operating room, same hospital by one surgeon, is cluster endophthalmitis. Now this is one report, retrospective case studies of post-operative endophthalmitis by after manual cyst surgery. 19 patients developed acute post-operative endophthalmitis within 2 weeks or so following manual cataract surgery. And look at it. The cases operated on that day, about 225 cases. Can you imagine? 225 cases operated. Out of that, 19 of them developed endophthalmitis. and we call it
checklist है ये
cluster
आपको करना जरूरी है
endophthalmitis.
must do for everyone checklist for
The intraoperative complication, you can see,
ठीक है,
they
मैं इसका
can
जब तक
be
करूँगा
contributory to the infection, as a matter of fact.
Malika knows each and everything
And the visual acuity, you've seen about hand movements and 165-60 movement. And the vitreous culture developed was staph epidermis and aureus. And the treatment given standard today, earliest treatment, they reckon if you make it late, the toxin and organism damages the photoreceptor just like that. I think even if you succeed, but the vision may not come back there. And look at the result, not bad, of the visual acuity. This is outcome at the end of surgery. This is the second post-operative cluster endophthalmitis referred to a tertiary center in Kathmandu from outside probably, about 11 cases. And there about 10 had small incision cataract surgery and one had extracapsular conventional. There was a rent in posterior capsule which can be contributory to the infection. And look at the visual acuity before operation, and there you are, very unusual. Two of them had E. coli, I don't know, intravitreal antibiotics. The standard treatment at the earliest is, I pointed out earlier by Dr. Burma, is the Cefta instead of amikin and vancomycin, and usually they use dexamethasone also, It has been the standard treatment in all these cluster cases. Not they have improved vision, all right. And this is the third one, again, cluster endophthalmitis. This is the study in the ICAM situation. I reckon, I don't think one should do cataract surgery in a camp, I suppose, situation. There you are, 18 total surgery, 89 and 18 developed your endophthalmitis. Visual acuity in most of them less than 360, and culture, it doesn't say which organism, but you see the positive and negative. Same treatment given intravitreal antibiotic, vancomycin and amikin here, and steroid. 6 underwent core vitrectomy, and the visual outcome you see in this case about 7 probably went on to phthisis also. Unfortunate. Now this is the situation of cluster endophthalmitis in Nepal. About 3 reports, and the message is probably not to get it. You got to be careful. Like I said at the outset, that the surgeon has to be very, very careful. They don't do well most of the time, and the treatment you got to start in the very, very, very beginning. Anyway, this is what our experience of cluster endophthalmitis, and the second is about this condition. We called it non-infective endophthalmitis, and here you see the moths here, and we reckon these white moths are responsible for this endophthalmitis. Let me. Now this is the long time back, I noticed these patients, usually they are children of both sexes, developing non-infective type of suppuration, which we called endophthalmitis, and in the beginning some doctors probably prefer to call it severe seasonal uveitis. The disease we found it very unilateral and characterized by, like I said, is sudden onset of redness of the eye. There is white pupil and profound visual loss, and you are not able to see the retina because there's a lot of exudation in the vitreous, like earlier pointed out. Endophthalmitis means inflammation with exudation into the vitreous cavity. The vitreous get involved in the very early stages. This was myself reporting 1978, long time ago. 78 means about 40 years ago, All my patients, about 13 cases, they were all around 10, 15 years of old landed up losing their vision, you know. And I think there were direct or indirect evidence of their being in contact with these white moths, you know, which used to be seen, you know, during that period of time, usually August, September. We used to call it tussock moth with different names to white moths. I remember one of these moths sitting on my hand, and when I removed it, I could see the little nettles, you call it, like the grounded glasses, you know. Probably the children rub their eyes, and mostly seen in the right eye, but you do see in the left eye also unilateral. And all of them, you know, rapidly developing signs of endophthalmitis, like characterized by white pupil exudation into the anterior chamber, more in the vitreous, which I label as endophthalmitis. And maximum that time I could do was injecting steroid, you know, mainly. I was so sure that there is no infective component in it, you know. I think it is just allergic response to these moths, I thought, you know. And all 13 children, you know, unfortunately lost their vision. And until then, I used to tell the people, and came out in the paper, to keep away from these moths. Keep the children away from these moths, you know, which appear during September, October. And then another study done, a colleague of mine, you know, also thought probably it has something to do with these moths, you know, though he couldn't find any organism growing from the vitreous or in anterior chamber, mostly from vitreous. So until then, you know, we're sure what the culprit is, you know, or was that time. So again, there is a colleague of mine, another, he reckoned probably same thing, the moths population high during that period. And what is said that probably if you intervene this patient, do vitrectomy, you know, within hours, if not within days, if you do within hours, I think he could preserve some vision in a few patients. And so, like I said, it says intense, the way the intraocular infection takes place so fast and rapidly in the vitreous cavity, he thought probably it is probably something like endophthalmitis rather than uveitis. And in this case, patient did recover some kind of vision because he did core vitrectomy, I think, within hours or days. So it's still a very confusing state of affairs. You know, we try to isolate bacteria. There have been some report of some bacteria being isolated, but this is a very new study, 2018. Still, you see there are total cases 66, mean age about 10, 11 again, you know, and look at the result. Look at the result. This is the recent one, 2018, and the vision at the time of presentation in children usually less than 360, and majority of them didn't improve their vision. So we feel that, you know, until we find a definite management, treatment, or a remedy to this condition, which we still label as idiopathic, if you want to call it, or seasonal, or endophthalmitis. I think for the last 20 years, 78 means 20, 40 years, we still are getting patients, children mostly, and if the child land up a place where there is no provision of vitrectomy, I think by and large they are losing sight, you know, from 20, 40 years, and we have not yet found a definite cause. No bacteria. There have been some report of identifying or bacteria getting involved, but not full proof yet, you know. So the message is, you know, until then, I think we got to keep our, at least warn our children, even adults, to keep away from these moths, which appears mostly during autumn season. Every alternate year, now they are beginning to be seen every year also, as a matter of fact. And if you have facility for vitrectomy, do vitrectomy whenever you see that there is no view of the retina. The vitreous is so much cloudy, you know. I recall one patient, which I have performed, when I did vitrectomy, there were all like cloud, cheese material in the vitreous cavity, and I was scared that maybe I shouldn't be doing more than just core vitrectomy because retina was just there, man. So that's it. So until then, intravitreal steroids and early vitrectomy have been found to be a little useful, but by and large, most of the children are losing losing vision, man. So I was wondering whether we see in this part of our South region cases like this. This is the reason why I made this presentation, or to share your views in this disease which is making children blind, man. That's the reason I think. Okay, thank you very much. So our problem is clustered endophthalmitis and this seasonal endophthalmitis. And regarding clustered endophthalmitis, I just said, I think there must have been some your experience we'd like to share.
Thank you very much. This is the international.
Suddenly, so I've revised the first part and I'll just go along. We had made these guidelines, the entire AIOS executive committee and many others from across the country, the leading retina and inflammation experts, in August 2018. These guidelines were made for prevention and management of endophthalmitis. So what was agreed was that pre-operatively blood sugar should be random less than 200 and fasting less than 140. Blood pressure should be controlled, which means less than 160 by 95. And pre-operatively you may do a test for the lacrimal regurgitation or syringing, but not on the day of surgery. It should be before the day of surgery. And if there is any infection on the lids or adnexa, not to operate. No contact procedures to be done on the day of surgery, whether A scan or tonometry. Preoperative topical antibiotics are not a must, but what is a must is povidone iodine application for a contact period of 3 minutes on the skin and in the conjunctiva. No clipping of eyelashes. The drapes to cover the lids, the lashes completely. Fitness to be received for every patient from a qualified physician, which can be MBBS as well, or an anesthetist if available, but fitness is required. In a mass surgery like where in camps, no more than 25.
We will stop here, Malika, and we will take the opinion from the house. So on all these points like blood sugar, so do you all do the same thing? Fasting sugar should not be 140 and random sugar should not be more than 200. Is it that? Please.
See, these things will be very subjective and variable, and each society may have its own guidelines, but it is ultimately left to the physician discretion. However, the judges may sometimes go by these guidelines and then you may be in trouble.
But in eye surgery, the role of physician is like that, na, ki we are creating a wound. So we are concerned about the healing and all those parts. So physician will say ki if you are okay with, you can go ahead with the surgery.
That's what I'm saying, there's no hard and fast rule.
Hello?
But ultimately the judges need some guidelines, and then a particular judge may decide to stick to it and say why did you do with 250 sugar or HbA1c 8. So these are just guidelines. But
so in this can we include the HbA1c limit also, something?
Now we can't include, these are already made in consultation.
No, we can include. That's what we are here to adopt. So we can include.
No, I'm talking of this particular set of guidelines. But
no, see.
include HbA1c.
How we came to the conclusion 200? How we
No.
came to the conclusion
Not
200?
sugar guy.
Is it blood sugar has any effect on eye surgery? I want to know something. Is there
No, Satansu, what you are saying, you have a point. Everybody knows here. So it doesn't have a direct relation. Somebody is a chronic diabetic. I know. Somebody is a chronic diabetic, he is having diabetes for a long time. You are not going to see, suppose if you are bringing down the sugar, you are not bringing down the associated problem which is there with the diabetes, the infection and all that thing, So this is just a broad guideline. It is not something very specific, but definitely what is mentioned here, it should be the postprandial should not be more than 200. हम भी यही लेते हैं 200 से ज़्यादा नहीं होना चाहिए. See, when patients come to you for cataract surgery, you can't run and find for a physician or somebody, that is another point. And then the fasting level which is given, 140. I think this is reasonably.
Taking my point. I have a case in the consumer forum running
Huh.
for life, ultimately happened. But all the pathologists write down blood sugar up to 140 is the BP is 100 to 140 normal. The problem is that we are saying less than 200 is normal. All the pathologists will write down 120 to 140.
See,
BP.
pathologist.
Are we safe in the group with this?
I don't think the pathologist, have to guide us on this. Yeah, because this is an AIOS guideline.
I think they've not mentioned at all.
Absolutely, absolutely.
Same.
One at a time, yeah.
Right. So what
Sir.
I personally feel that, yeah, please.
Yeah, I think it is from the American Academy of Ophthalmology.
Are you sure? Because it may not even be there. As they have probably left it to the discretion of the physician. They just say sugar should be within normal limits.
Sir,
No, not skip, not skip.
sir, one of my patients, sir, can I share my experience? One of my patient, I did the surgery with a 140 blood sugar level, and patient had an endophthalmitis. After the infection, I checked the HbA1c, and that was 8. In that time, that was a medical legal issue. I think HbA1c should be included because.
I agree with you.
Yeah. And another one is in the Japan, they are following HbA1c less than 10 and the postprandial blood sugar less than 10.
I think,
it should
I
be.
think,
Infection, avoid surgery. What is FGD? Regurgitation.
no, MGD,
Sorry?
it cannot be a guideline, Not many people know about MGD, number one. Not many people have the facility to diagnose MGD also. Now there are new technical things. Huh? Huh? We'll be having MGD.
That's right.
And then pre-operative topical antibiotics. So what is your suggestion?
Yeah, worldwide it has been.
So the debate is whether given for 1 day or 3 days prior
Yes,
to
that
surgery.
is.
Right, sir, not mandatory.
Non mandatory. Chalo. So the next is physician clearance. Not mandatory?
No, that is mandatory, sir. If something happens on the table, we are liable.
There is a systemic involvement.
Systemic illness.
Yeah.
Absolutely.
Yes.
Only for systemic illness at least.
इसमें लिखा है.
When required.
Very लिखा है. Very required.
When anesthetist, I require.
इसमें लिख देते हैं.
When required.
Yes, it is okay.
No, I will write when there is a systemic problem or
Sir,
systemic
many times
illness.
we don't know there is a problem unless
सब
they do.
distribute कर दो.
Sir, how will we know there is a problem if unless we know how to read the ECG, we don't even know how to read the ECG. No, but ECG may show some impending changes. We don't even know that. We
No,
can't
but
understand.
we don't need to do ECG in every patient. If somebody is a hypertensive, he doesn't have any cardiac problem or anything. Because if normal patients, you will do above 60 ECG, every patient will have something in the ECG. And on pretext, you just can't avoid the
No,
surgery.
sir,
You just don't
when
say.
something happens, then nobody will excuse us for taking a sick patient on the table without a clearance.
I will
and
tell
we
you-
don't even know it was sick.
I will tell you something.
Sir, patients misguide history. Patients even misguide about the history when they want
That
surgery.
is true.
So they will not even give you the history.
Can you write the age after 60 years should be have medical fitness or like? Certain
They will not even give you the history mostly.
So you mean
One by one, please.
One by one.
One by one.
we should have all patients for sent for the future test?
Absolutely.
Not possible. Only the patient's history.
When you have a problem,
Yes.
that time you will be hard. That's all.
Possible नहीं.
Sir, so diabetes is a problem. So hypertension is a problem. Cardiac, any types of cardiac problem. Patient is under blood thinning agent. So in that cases we have to stop. In that cases, and some renal problem is a problem. I think some basic investigations we can do, ophthalmologist, without any physician's opinion. And if there is any problem, then we can refer the patient to the physician. If we will. No. I'm not telling about the ECG. Actually, the blood sugar, blood pressure, and the.
It is written here, physician's clearance is not mandatory. Yes, it is the discretion of ophthalmologist.
Yes.
I like to mention here, this is a guideline for not a very high institute or a very big corporate hospital. This guideline we are making for the entire SARC region. We have different kind of setup in different country. So keeping that in view, we have to frame these guidelines. This is very simple.
See, keeping even camps in view, it is a mandatory to have a physician there who examines the patient before you take surgery. So even for mass surgeries, this is mandatory. And
No, man. Physician.
Another thing, you cannot even operate without having at least a trained life support technician. That is also mandatory. So at least send your patients to him for pre-surgery checkup. At least he will pick up the problems on the ECG, on the tests. So anyway, you have him in your team.
Malika, we have the list of equipments which is needed when we are doing a surgery. Maybe, defibrillator and other things, maybe they are already mentioned there. But again, I will say this is a broad guideline which you are framing here. If there is any specific need in a specific setup, they can always go for it. Yes. So that we must keep in mind. Where required or whenever there is a systemic problem. Whenever there is a systemic problem. Next. In mass surgery?
Yeah.
In mass surgeries, okay. So in mass surgeries, the number set has been by, this is not more than 25 eyes per surgeon per session of 4 hours. So the same surgeon can do 50 eyes also, but in separated 2 slots, 4 hours each. And patients in camps, multiple systemic problems, surgery should not be done. Combined surgeries should not be done. High risk cases and topical surgeries only very highly experienced surgeons with all due precautions. One-eyed patients should be avoided unless patient's condition is such that they cannot go to the other higher hospitals. Emergency services should be left available for 1 week in the area, and dedicated IOT should be there in a hospital setup. No surgeries in a makeshift OT in a rural area. It should be a...
I think this is all agreeable. Yes, Sudhanshu?
No, that's already over, sugar and BP.
Sir, I want to say one thing, very important. Recently, one time, I have to operate 3 cases of hepatitis virus positive. I was not knowing. They told my staff that we have been cancelled from the social theory hospital there in the medical college. They did not told me they are the hepatitis virus because they check everything in the medical college. So, and Dr. Deepa Mishra has a very good...
Is a must for surgeries.
Post-op problem.
Now, about the surgeon. For high risk cases.
For high risk cases.
3 or more comorbidities. Okay, surgeon, anyone include doctors or staff with an obvious infection should not be allowed to enter the OT.
Yes.
Shoe covers over the street shoes is not recommended. So better to wear a different pair of footwear, slippers with a different color coding, which is washable slippers. And for the bathroom in the OT, have a separate bathroom slippers. Clean washed OT dress. No street clothes should be allowed inside the OT for anyone, including doctors. And washing, gowning or gloving as per standard protocol for all OT personnel. Hand washing to be done with betadine or chlorhexidine scrub for 3 minutes. And no bar soaps to be used, liquid soaps. Purified water or potable water to be used for scrubbing. OT etiquette to be put up on the walls. Important do's and don'ts should be placed on the walls for all staff. Sterilized gloves for every case, new pair. Use chemical disinfectant between cases if you cannot wash between cases again, the surgeon or even staff should at least wash between cases or use these disinfectants. Sterilized gown is mandatory over the OT dress. Surgeon should not come out of the OT in the OT gown, or if he comes out he must again scrub fully and change for the next case. Mask should cover the nose and mouth properly. OT cap to be worn properly, tucking in all the hair. Position of hands after scrubbing and gloving should be above the waist and upright in front. Document the sequence of surgeries so that when there is a problem you know what happened. Intraocular.
I think these are all okay. Any? That should be there.
Yes, it should be
patient clothing and the cap. Yes.
Clothing and cap.
Clothing and
in
cap.
camps we don't change the patients, do we?
Patients patient hair should be covered by a cap, and maybe a gown can be used for patient also.
So this photo should be eliminated from a video.
Okay. We'll put on a different photo, okay?
We will not use this photo.
कौन सा फोटो है इसमें तो है ही गाउन तो बना हुआ है ये बना कौन सा
Gown,
फोटो बोला है?
surgeon's gown. No, it
कौन सा
makes
फोटो बोला?
different.
ये बाल वाल दिख रहे हैं ना पीछे.
तो बाल तो दिखता है
Water
सबको.
resistant type of gown must be there, in my opinion.
What is
Same
your
thing,
suggestion?
same thing.
Same thing. Is there anything else? Yes. Then next, irrigating
Intraocular
irrigating fluids.
So 1-for-1 rule, 1 bottle of irrigating fluid for 1 patient. Note the batch number.
Yes, please.
बेटा इसके ऊपर थोड़ा डिस्कस करना पड़ेगा.
हाँ करना पड़ेगा.
For private petitioner.
करना पड़ेगा.
Normally, we are now intended to 50 ml. Normally, we have 500 ml bottle. Is it practical in country to recommend this one bottle one? I am a special course also. I am saying one bottle, but out of the four, I have to say, but this is recommendation cannot.
I think it's ideal, but for practical purpose, it's not possible.
Otherwise, you in the course sometime you cannot.
You make it preferably.
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 And because we will be.
See, I don't know whether it's how much is the cost of each bottle. I think sometimes we just go without any. So what's the big deal? I mean, how much are we charging the patients also? I think we are just charging the patients but not want to give the benefit.
Hospitals are also there. Charitable hospitals are also there. So it will be off for all. If we make recommendation, it will be for all. For charitable also.
And for
Between
ringer,
cases, when there is a waste of time, the bottle and the tubing is all open and somewhere it is lying. Now you are trying to keep that end sterile so that you can use it in the next trolley. And meanwhile, the staff is gone to scrub again. What's the point? Just
So there are various
We can leave it like that.
about the
preferable.
ringer
ringer lactate,
they
yeah.
have mentioned it's only IV fluid. So ringer lactate is okay. Sorry? Yeah, so as the guideline is saying, we can use the ringer lactate.
hospital area for 3 minutes or till dry before draping. Boundary being the hairline, tip of nose, nasolabial fold and external ear. Disposable adhesive drape to isolate the lashes to be used in each surgery. Speculum is a must and 5% iodine to be instilled in the conjunctival sac. Wait for 3 minutes before washing.
It's okay.
At the end of surgery, subconjunctival antibiotics is not necessary. Topical broad spectrum antibiotic drops can be instilled.
Not necessary means if anyone wants to give
Yes,
subconjunctival,
He can give.
he should have some preference.
Yeah, obviously it is there.
It's not
Mandatory.
It's not mandatory.
Not necessary.
Not necessary.
Necessary, but mandatory.
Yes, it should be not mandatory.
Mandatory.
If you give some
Yes.
Non
Yes,
mandatory
not
कर देते हैं.
mandatory. You just write down. Not
Leave
mandatory.
the non mandatory.
3 minutes is
Standard.
standard thing. Where
I think we can write 2 to 3 minutes.
2 to 3 minutes. Okay.
2 to 3 minutes. I think let it be 2 to 3 minutes.
Not to be entertained.
Yes.
Yeah, not fine.
वो कर दिया.
no harm, but some people
That's
don't
why
want to
it is
give.
no mandatory. Not mandatory means if you want, you can give.
You can give intracameral also if you feel like it.
Yes.
Intracameral, everybody gives intracameral, I believe
Sir,
now.
sir, just a question. Like there are a lot of studies on intracameral antibiotics. These are mostly meta studies, and in spite of all those things, FDA is not convinced that intracameral should be used. So I just want to know the opinion of all members here. Should we go for it or should we not go
It
for
should
it?
not be made mandatory. It can be optional.
FDA is not convinced so far that it, yeah. And
Because it is adding one
all
more
the
step